The human heart is situated in the middle mediastinum of the thoracic cavity, protected by the rib cage. It sits obliquely, with approximately two-thirds of its mass positioned to the left of the body's midline. The broader superior portion is the anatomical base, while the pointed inferior tip, the apex, rests on the diaphragm. Beneath the protective pericardial sac, the heart wall is composed of three distinct histological layers. The outermost epicardium covers the massive myocardium, the thickest layer built of involuntary striated cardiac muscle fibers. These fibers power continuous rhythmic contractions, while the innermost endocardium provides a frictionless, non-thrombogenic lining. Deoxygenated blood from the systemic circulation enters the right atrium via the superior and inferior vena cavae. During ventricular diastole, blood flows across the open tricuspid valve into the right ventricle. Notice the chordae tendineae tethering the valve leaflets to the papillary muscles, preventing prolapse during systole. Moving to the left side, the left atrium receives oxygen-rich blood returning from the lungs via the pulmonary veins. This blood flows through the mitral or bicuspid valve, down into the left ventricle, the heart's primary engine. Notice the left ventricle's massive muscular wall. It is significantly thicker than the right, designed to pump blood against high systemic pressure to the entire body. To maintain strictly unidirectional blood flow, the heart relies on four highly specialized anatomical valves. From a superior surgical view, we first identify the atrioventricular, or AV valves, the tricuspid and mitral, separating atria from ventricles. During ventricular systole, these AV valves snap shut to prevent retrograde flow, producing the first heart sound, lub. Simultaneously, the aortic and pulmonary semilunar valves open. Their subsequent closure during diastole creates the second sound, dub. Zooming out, we observe the great vessels. The Vena Cavae return deoxygenated blood to the right atrium. The pulmonary trunk splits into arteries, the rare exception carrying deoxygenated blood to the lungs. Finally, the robust aorta withstands immense systemic pressure, distributing oxygen-rich blood through its arch. The myocardium relies on its own dedicated blood supply, the coronary circulation originating directly from the aortic root. The right coronary artery supplies the right heart, while the left main branches into the circumflex and the left anterior descending artery. Crucially, the latter supplies the anterior left ventricle, earning the clinical moniker widowmaker when critically occluded. The heart's rhythmic contraction is driven by its intrinsic conduction system, beginning at the sinoatrial, or SA node, the primary natural pacemaker. This electrical impulse sweeps across the atria and pauses for about 0.1 seconds at the AV node, allowing the ventricles to fully fill with blood. The signal then races down the bundle of His and Purkinje fibers, triggering a powerful synchronized ventricular systole. Let's trace the complete journey of a single red blood cell returning deoxygenated from the body via the vena cavae into the right heart. The right ventricle then pumps this blood through the pulmonary trunk to the lungs for oxygenation. Oxygen-rich blood returns to the left atrium, dropping into the left ventricle, which forcefully ejects it through the aorta. This continuous loop perfectly illustrates the heart functioning as two synchronized pumps in series. Understanding this precise anatomy is the foundation of clinical diagnosis, guiding both auscultation and cardiac imaging. For instance, a myocardial infarction occurs when a coronary artery occlusion leads to localized tissue ischemia. Ultimately, heart failure is defined anatomically as the inability of this muscular pump to maintain adequate systemic cardiac output